Okay, great. Thank you so much. Okay, thank you for the invite, IAC, and thank you, Mudassir, Asif, and Shahid, for really extending this invite to me. And Syed is always a tough act to follow, and his cases were beautiful, and I'm glad he took time to really give you the rundown for IAC. And if you can, please join and visit us in US also, because we are going to have an American Society of Cytopathology meeting in Austin, Texas in November, and me and Sayed will be there. So with that, I'm going to get into the topic because I want to make sure that I end on time so you guys can eat lunch and not be hypoglycemic, because that is not a good thing to have and attend all these talks. This is my first talk is going to be on salivary gland cytopathology, and at the bottom there are three great spots in Philadelphia. So if you happen to be in Philadelphia, Philadelphia is a very walkable city, and I really love to walk to work. So some of these shots that I've taken, especially the Ben Franklin one, is mine. So you guys can, if you're in Philadelphia, come and visit. And the campus is really great for the pen, and Philadelphia is an excellent city. So I'm going to start with these two shots here. And this is actually, if you ever happen to be in Louvre in France, these are etches, which are wooden blocks by artists. And you can see these are salivary gland tumors, most likely pleomorphic adenomas or giant sebaceous type adenomas in those days. So I'm going to take you very quickly through the advantages of salivary gland FNAs, which are done by a very thin needle. All of you know what FNA is. And I think it really helps to differentiate inflammatory from neoplastic diseases, infections, which are also can be common. But when it comes to diagnosing very, very specific tumor cell types, it kind of does poorly, but it does diagnose the most commonly occurring tumors very well. It also helps to diagnose tumors which are metastatic versus the primary salivary gland tumors. What I really find this to be helpful, because the salivary gland, especially the parotid gland and submandibular gland, is around too many lymph nodes. And even in the parotid glands, there are lymph nodes, and which can be the site for metastatic squamous cell carcinoma, especially those arising in the scalp or head and neck region. So, biopsying this can be really helpful to make a diagnosis of squamous cell carcinoma, which is really actually important. Since I talk about FNA, I always put the slide that, what are the disadvantages of FNA. There's always complications because whenever you stick a needle into the arm, but as long as you stay with a very needle which is very thin, that means a higher gauge needle, there is not many infections or hemorrhages you're going to cause unless there are contraindications. I do not like core biopsies and with salivary gland lesions, because tumors like pleomorphic adenomas can really track into the wound. So I think the FNA does a pretty good job. So I'm going to spend some time, since I do also surgical pathology and I sign out these cases. Our gold standard in cytology is always the surgical pathology. And let's see how that standard is gold. So let's take the classification, the search path classification. This is a very interesting slide, as you can see, from 1972 to 2017, how this classification has changed. And this was purely morphologic-based classification. But if you look at the most updated classification of the salivary gland tumors, it includes the molecular classification. So the molecular profiling is becoming very important, because it also defines how these tumors are going to behave. Plus, it provides targets for these tumors to be treated when the surgery is not enough. So, and these molecular markers can also help us to diagnose these tumors in a very small and limited specimen, which is the FNA specimen that we get from these tumors. So let's look at the diagnostic paradigms that we follow for surgical pathology diagnosis. So when you look at the malignant tumors, we look at invasion, whether that's a gross invasion or the microscopic invasion. And the perineural invasion is the one that you see in most salivary gland tumors. And then you have angioinvasion, or they are invading into the surrounding salivary gland parenchyma. But when you look at the benign tumors, this is not so clear-cut because you can also see in the benign tumors where they can have a multilobulated growth, pushing borders, lack of encapsulation, and even outpouching in the surrounding thyroid parenchyma. Plus, you have intraductal tumors, the most common being the salivary duct carcinoma intraductal type, which does not show invasion. It's all intraductal process. So this is where the invasion then gets a little muddied. The other thing is cytologic features of malignancy. The marked nuclear pleomorphism, atypical mitosis, and tumor necrosis. So I just showed you a case of a squamous metaplasia, which almost looked malignant, or looked malignant actually on cytology. So if you use those criteria for malignancy, and then you look at the other malignant tumors like adenoid cystic carcinoma, that is the most monotonous cell population without any necrosis or without any nuclear pleomorphism. So this is where I think it is not so clear cut. But then the benign tumors can also show mitosis, even nuclear pleomorphism, which I call an ancient change that we see in schwannomas and other tumors. Similarly, we see in other tumors like in thyroid and salivary gland, if those tumors have been there for a long time. Patients also can have a prior FNA, and that can cause really problematic cells in these tumors. So this is not such a clear paradigm. Plus, the cell type, and I think this is very, very important for us to understand that there's a lot of overlap on the cells that tumors are arising, and which gives rise to heterogeneous morphology. And even that makes the things more complicated in those smaller samples from FNA or biopsies that we see. Now, the myepithelial cells we always talk about, we always say myepithelial cells. This looks like a myepithelial cell because it's a spindle cell. This looks like a myepithelial cell because it's a plasmacytoid cell. Now, if you look at the makeup of the myepithelial cells in benign and malignant tumors, you can see the list is pretty long, and that really makes things more complicated. Immunostains. So though no specific immunostain really works because some of these tumors can have overlapping immunostain profile also. So I'm just showing you like a mugshot of these to just make sure that there is a lot of heterogeneous morphology that we are dealing with. And I think that makes our job as a cytopathologist and looking at these tumors very difficult. But you also have to understand that the cytology is very good in diagnosing the most common tumors that we see as pleomorphic adenomas or Wharton tumors. And what it does, it also provides management options. One of the most important things is that when a patient has another cancer, they get screened a lot. And during this screening, salivary gland tumors and the thyroid tumors, the head and neck actually tumors, really found incidental tumors really show up on these screening techniques. And that's why we are seeing more and more of these specimens. At least I see a lot of these, and I'm sure Momin and Sayed see these a lot in their practice, and you also. So because of this heterogeneity, the Milan system came into view, which is now, the second edition is going to be out soon, also or is already out. There is, like the Bethesda classification for thyroid, the Milan system provides a reporting framework. And I think these reporting frameworks are not just providing you diagnostic categories. They're also being true to the practice of cytopathology, where there's a spectrum of diagnoses. You have benign, you have malignant, and then this middle ground, which is where you cannot exactly make a diagnosis of malignancy. And so in the Milan system, you definitely have a non-diagnostic category, non-neoplastic, which are more of the inflammatory conditions, then atypical, that means I do not know whether this is a neoplasm or inflammatory. Then the neoplasm, in which the most common will be the benign neoplasms that we see, which make up a whole huge chunk of these diagnoses. And then salivary gland, neoplasm of uncertain malignant potential or some. That means that is maybe a benign neoplasm or maybe a low malignancy. But those malignancies tend to be more low risk. And those are the tumors which kind of overlap a lot with the benign tumors. As with any system, when they come out, it is based upon the literature review, and then everybody uses it. that's where the associated risk of malignancies, which are with every single diagnosis here, kind of change. So you can see here, these are the average risk of malignancy. And then when it came out in the literature, these changes. But I think it's very good because it helps us to refine those risk of malignancies for the, but my thing is, let's not think about risk of malignancies. It's more of a conversation to show and personal QA. But if we look at the predictive values of the diagnoses we make with the malignancy, you can see they are really above, close to 90 or above 90, which is, to me, really matters in these cases. Now, let's look at how we diagnose these tumors. And I think it's about with the pattern recognition. And to me, that pattern recognition really also correlates with what we see on cytology. So the architecture of a tumor really correlates with what I call as more like a macro architecture on histology or cytology, kind of really correlates to what you are going to see on radiology. And it causes that different patterns that you will see on a cytology material. What is the cell type? Based upon morphology, we can only do so much. It cannot be always 100% because of those heterogeneous cell population, stroma and basement material, and background. So in the bottom line is everything matters in that limited cellularity specimen. The most common tumor is the benign mixed tumor. It is 2/3 of the parotid tumor. It's also common in children. It's always circumscribed, firm, and rubbery on clinical examination. So if you're doing your own FNAs, feeling that tumor between your two fingers and moving it around, that rubbery consistency is always basically 90+% of the time you're correct that this is going to be a pleomorphic adenoma. The two most common things that you see in this tumor is epithelial cells and the myoepithelial cells. And the cell shape that you see is either most commonly they're plasmacytoid cells. That means the nucleus is sitting at the edge of the cell. Or they're epithelioid cells, which have bigger cells, almost kind of macrophage type quality, but very round and plump nuclei and a denser cytoplasm. They can be also a spindle or clear cell. So I talked about the metaplasia. This is also one of the common tumors that can have metaplasias in it, and that can really make the diagnosis a little bit difficult. The matrix is very important in these tumors because it has these frayed edges and it individually surrounds each cell. So let's talk about and look at the illustrations for this. So this is one of the cases that I always show, which is very important case. And you can see on radiology, this is a very circumscribed tumor. This is where the needle is. There is really no infiltration in this on the surrounding edge. So it's a very low risk neoplasm. And most commonly, this is going to be a picture of a pleomorphic adenoma. It's very hypoechoic. That means it has cells and stuff which make the ultrasound waves go through it and really not cut much of a brighter shadow. And when you look at on the cytology, you can see here, these are the cells, and there's a close association between the stroma and the cells. And as you can see, some of these cells have very plasmacytoid appearance, as we talked about. So that plasmacytoid appearance is very typical of myoepithelial cells. You can see them in benign as well as malignant tumors. But that stroma association and the cells embedded within the stroma is very common finding in these tumors. Some tumors can have a lot of cartilage in them, and you can see this fried egg appearance is very typical of these cells. Plus, they have this, they almost like a lacunae type. So this is really a cartilage forming tumor, plus that clear cytoplasm and really nondescript nuclei. Now, when you throw them on thin prep, this stroma kind of goes away. And this is where I had to teach myself a lot, where you can mostly see cells. You don't see that really beautiful stroma in so much amounts as you see on the smear. So I really like smears on these cases. But if you really look closely, you can see stroma in this. So this type of stroma with the frayed edges or the edges which have this feathery appearance is called the troll hair stroma that everybody uses. And just a little tidbit, the troll hair is that doll actually goes long way back. It's actually one of the Danish woodcutter who actually made these dolls, and this was first introduced in the United Kingdom. So that's where this troll doll, which some people actually collect. I don't know why, but no judgment on my part from this. These tumors can occur a lot of places. They also can occur in parapharyngeal spaces, and this is actually one of the tumors that I was involved in diagnosing. And as you can see here, on CT scan, again, these tumors are very circumscribed. They really do not have any invasive edges, and you can see that there's a really nice rim of the salivary gland tissue around it. So these tumors again have whatever smears you do. On the DiffQuick is the best, or Romanowski stent smears will show this beautiful stroma in these tumors. And again, this cartilage type material plus the spindle and the epithelioid cells. Now, those are the classic cases I showed you. What happens when these cases do not really reading the books or the atlases that you're so used to seeing? So there can be a lot of heterogeneity in the morphology of these tumors. And this is what it scares me the most when they go under cystic change. When these tumors go under cystic change, the background of that stroma that we see changes, but something is still follow. One of the things happens to the stroma in these tumors when they go under cystic change is the liquidity of that stroma. That stroma becomes very liquid and can mimic mucin. But if we look at the cells very closely, they are still those plasmacytoid cells and very closely associated with the stroma. On the thin prep, these tumors have that spindly appearance. So once you see these spindle cells and there's nothing else going on with the patient, that is the only lesion. Most likely that is a pleomorphic adenoma because you have a mixture of these rounder epithelioid cells and these spindle cells. And if you look at the chromatin, it's very evenly distributed chromatin. And this is one of those cases, and you can see that really large cystic spaces in these. And some of these cystic spaces can have clear cells in them. And this is the high power, which shows you this very like a liquidy like stroma, which is not that dense stroma that you see in these classic cases. Some cases can also have these oncocytic cells. So some of the cells can be very pinky or eosinophilic cytoplasm. But if they are combined with that stroma, then you know that you're dealing with a variant, morphologic variant of a pleomorphic adenoma. They can be very, very cellular, but again, that stroma can be seen within the cell groups. The other thing I want to point out, which is very important, is that when you get these tumors, look at the cells, and sometimes the cells can have beautiful intranuclear inclusions. That is very typical of myoepithelial cells. So this is one of the cases which was very cellular, so these tumors can be cellular. In rare instances, these tumors can go under squamous metaplasia and can actually have keratin in them and can be mistaken for a mucoepidermoid carcinoma or even a metastasis or a squamous cell carcinoma. You can see again so what I do, I always look at the cells first before I really focus on this squamous cells. And you can see here the spindly cells, and the cells have these little tentacles coming out of that. So that is the stroma association along with the cytoplasm. And you can see in these tumors, there was really a beautiful squamous metaplasia and even keratinization. You can see how challenging these tumors can be. And because of this, sometimes these tumors are called SUMP because there is squamous differentiation. But when you look at the squamous cells, they're really very mature squamous cells in them. They also can go under sebaceous differentiation. So what happens when this tumor is not following the rules? It's going to mimic other tumors. It can mimic basaloid tumors. That will be the generic category, with the differential being a basal cell adenoma or an adenoid cystic carcinoma. And this tumor can have these tubular structures. But if you look at the cells, some of them are spindly, some of them are round. They really do not have that chromatin that you see in adenoid cystic. But these tumors can be very challenging because they form these tubular structures, which can mimic those tubular structures that you see in adenoid cystic carcinoma. And this is, again, a very cellular pleomorphic adenoma with that tubular formations in them. This is another case of a cellular pleomorphic adenoma or a VMT, and you can see this one had really beautiful cores in it, which exactly look like. So this is where I think when these tumors are being sampled, and if you are sampling them, just don't have your needle stay in one area. Attack multiple areas within the tumor, because you can see here, there is a classic morphology of pleomorphic adenomas surrounding, but then these tubular structures in this specimen can look like adenoid cystic. So these tumors can be misdiagnosed as adenoid cystic. Immunostains can help, and now they do have PLGA, which is the Plaga antibody available. So you can do on it. It will tell you this is a myoepithelial tumor and most likely pleomorphic adenoma, but this can also be positive in other low-risk malignancies. So I think the morphology really matters. So I'm going to move into adenoid cystic carcinoma. I'm going to spend a little bit of time on it because this tumor can give problems on cytology. This is the classic representation of adenoid cystic, where you have these globules of basement membrane. What I want you to notice, there are no cells embedded in the stroma, and then these are very monotonous cells kind of encircling these. So this is like a classic presentation. These tumors have a higher rate of recurrence locally and can have actually distant MEPs. They can affect any ages. They're more common in women. They can affect major and minor salivary glands. In prostate, they are not that common, and they can have these very oval nuclei, which are sharply angulated. Plus, they have nuclei which can be opened. So I'm going to go through some histology cases to just show you these. Their molecular profile is MIB-NF1B fusion, and there's an antibody for MIB available, which can be used for these, and they can also be c-KIT positive. Some tumors are not c-KIT positive. So that does not exclude the diagnosis of adenoid cystic. This is the classic pattern that we see. Basaloid cells arranged in this cribriform pattern in the background of hyalinized stroma. What I want to point out on this search map, what we see on cytology is this very sharp and angulated cells and the cribriform pattern, but there are actually two cell types in this tumor. And then this very hyalinized stroma that gives rise to that acellular basement membrane material, which is surrounded by those monotonous cells. I do want to point out that some of the nuclei have a very open chromatin, which is very, very important. But notice these really sharp and darkly angulated cells, which is really, for me, on a search path, is very important to make this diagnosis. Let the high power again to show you those sharply angulated cells here. But look at some of the cells have a very open chromatin. The thing to notice is the scant cytoplasm. So the basaloid cell from adenoid cystic carcinoma has very little cytoplasm, but you can see this also in basal cell adenoma, plus in some other tumors which have basaloid morphology, including pleomorphic adenoma. Again, I'm just showing you the repetition just to say, because this is where we are going to correlate our cases. So those angulated cells and the cells with the open chromatin, they can also have a solid growth pattern. On ultrasound, they have irregular margins, which is very important. That means it's an infiltrative tumor. On classic cytology, as I showed you, these are basaloid cells. Again, notice those sharp angulated cells, which are darker, and some cells are larger with an open chromatin, that acellular basement membrane type material, which really mimics what we see on histology. So this is a classic representation of an adenoid cystic carcinoma. Now, when you use the alcohol-based slides, which are alcohol fixed in 95% alcohol, and then you do the pap stain on these, or you use thin prep material, that beautiful stroma, or the amount of the stroma, goes down. So you may see these empty or hollow tubular formations. But again, if you really notice on this, this is just the way the stroma is not gone. This is the way it's staining. So you see this almost what I call it a stained glass appearance. That stroma is still there, and you can see the cells that are surrounding it. So there's no cells in it. This is just a three-dimensional kind of look to it. So you can focus up and down and you can still see the stroma, but look at the sharpness of the structures. This is the thin prep specimen where the stroma is kind of gone, and what you're seeing is this really just tubular formation. So one has to be very careful when you're looking at these on the thin prep specimen. And this is, again, was a surgical pathology follow-up on this case. Sometimes the stroma is actually sitting somewhere else on the smear or on that thin prep specimen. And this is actually one of the features on the alcohol fixed slides that we see. So look for this stroma, again, that rounder stroma kind of taken out from those cells and sitting outside. So as I said, everything matters in these cases. So you really have to look at the entire smear and the entire slide to really make the diagnosis. Because if I just take these without looking at the stroma, I may be making different diagnoses. But that stroma to me is very suspicious for adenoid cystic. And this was the surgical follow-up on that case. So when you're looking at the basaloid cells, your differential includes the benign neoplasms like pleomorphic adenomas, basal cell adenomas, adenoid cystic carcinomas. And if you do not have typical histology or cytology, actually, like for pleomorphic adenoma or other tumors, it's okay to say it's a basaloid neoplasm and give the differential. I always put the closest differential that I have higher on my list because I think that really helps them how to manage these patients. So this is the differential, which is actually in the Milan book also, of when you see the basaloid cells and then you see the stroma. So the type of the stroma and the type of the basal cell kind of arrangement with those stromas really matters for you to arrive at the exact diagnosis. But my advice will be never to push yourself into a diagnosis. Somebody says, no, it is malignant. Let them sign out that case. But if you are really wary about it's good to give the differential to a surgeon and then tell them, look, I really cannot make exact diagnosis, but these are the tumors that I'm thinking of. This is another case where you have nothing but basaloid cells. There are basically no stroma. Notice the cohesivity of those cells and even sometimes molding among those cells. But if I go very closely around, I do notice that some of these cells are kind of palisading on the edges. And this is actually the alcohol slide. And you can see this beautiful palisading. Now, this is a pattern that is very typical of basal cell adenomas, but they can be mistaken on cytology for adenoid cystic carcinomas because that monotony of the cells like basaloid cells, and very little stroma or deep holes within them can mimic adenoid cystic. So basal cell adenoma, again, is more common in women than men. And the histology is very difficult. I sometimes find this tumor to be very difficult to diagnose because if it does not follow the typical pattern, because it has many patterns in there. The larger cells are more in the interior of those basaloid nests, and they have more abundant cytoplasm. And I will show you some examples. They have different patterns, and I'm not going to go through all of them, but I'm just going to show you how heterogeneous morphology in this tumor can be. They are keratin positive tumors, but they can also be positive for SMA, P63, and they are beta-catenin positive, which is really good marker for these tumors. And because of that, because they're positive, you can see that they have CTNNB1 mutations, which is associated with this. And this is very highly specific for these tumors. But I think the beta-catenin stain really helps to diagnose these tumors. The membranous ones are associated with familial type syndrome, and they actually have CYLD1 alterations, which is the Brooke-Spiegler syndrome, which can have other trichoepitheliomas and other tumors associated with this. So basal cell adenoma on histology, a circumscribed tumor, no infiltration, it's just a mass of cells in this, and very complicated kind of pattern, but very monotonous pattern. But if you look at these on histology, you can see that beautiful membranous stroma, which is surrounding each cell, which is very typical of these tumors. Again, the basaloid cells forming these tubules, and I call these sometimes abortive tubules because you can see how small these tubules look. These tumors can also have clear cells in them because they can turn cystic and can have like a sebaceous type differentiation. But I want to point out, notice that beautiful membranous type material here. As I said, these tumors can be cystic and sometimes can mimic other tumors or can have clear cells or sebaceous type differentiation. They are beta-catenin positive, so if you get them on search path or if you have a good cell block, doing their sustain really is helpful. Another tumor, which is a 2.8 centimeter ill-defined mass, and the tumor background is very blue. And if you can see, it's very smearing smoothly. This is very typical of mucin. So when you have a mucinous background, then your differential is going to change. Now here you can see this is a cell group with a very sharp cytoplasmic borders, which is epidermoid type cell. And here I want to show you this on a high kind of just pull through, zoom through it, and you notice the glandular cells in the background. So you have epidermoid cells, you have these clearoid cells, which is kind of a grouping, and then you have this really mucinous or glandular cells. So you have good three components. You have mucous cells, you have epidermoid cells, and you have intermediate cells. And that is very typical of mucoepidermoid carcinoma, specifically the low-grade types. Now, this is the follow-up, and again, it points out to you those really pinky cells, which are the intermediate cells, the mucous cells, and we'll see it on a more high power. So this is what you see, and I'm not going to go through this. This is all in atlases and books, but I think noticing those glandular or foamy cells or mucous cells, epidermoid cells, and intermediate cells. So here you can see the glandular cells and the intermediate cells is very important, and the epidermoid cells to make this diagnosis of this tumor. This is again more common in females. They can be tender or they can cause facial paralysis because they are malignant tumors. More common in the parotid glands. And I think it's important to notice that these tumors have this specific translocation, which is CRT-C1 mammal2, which I use actually in cases where there's a difficulty in diagnosis because it really helps the surgeon to plan their surgery. So if you can do FISH on these tumors, if it is available, that really, really helps. There are low-grade tumors, and then there are high-grade tumors, depending upon which search path classification you follow. There's a classification, WHO says you can use 3-grade classification for search path specimens, but from cytology point of view, if you see those cells, calling it mucoepidermoid carcinoma, I think you have done your job. Just a close look on the search path to show you the mucous cells, the intermediate cells, and then those epidermoid cells, which have a little bit of that eosinophilic cytoplasm. So you have those 3 cell types, which I think you can see on cytology. They can have mucous pools, which is for the low-grade tumors because they are cystic, and that's very typical, that mucous background. So looking at the background is very important in diagnosing these tumors. They can also be very low cellularity specimen. But I want to point out this beautiful background, and mucin always gives you these thick strands in the background. So if you're saying that this could be clot or this could be sedum, which can mimic even colloid and mucin sometimes in a more of a hemorrhagic specimens, looking at the quality of these kind of empty spaces, the thick kind of strands and the pasty type look in the background, you can be sure that this is mucin. And you see this also in pancreas, and I'm sure Momin will talk about it. So again, these limited amount cellularity specimen, but having those foam cells, the group of intermediate cells, and these epidermoid cells really helps you to say that this is a mucoepidermoid carcinoma, and this is the follow-up. Low-grade tumors can have extra visited mucin or with large cystic spaces filled with mucin. You have to be careful because there is a differential for these tumors, and which is most, the funny ones are the benign tumors that can mimic these things. So you have to think about the other tumors or other benign lesions that can mimic these tumors. One of the common ones is granular, which is more likely to be around the mandible and in the submandibular space. But if you have a good astute radiologist, they will always tell you this looks like a ranula because it looks a very hypoechoic lesion, which is cystic, It doesn't have any solid components. And what you get is this mucinous background. Kind of look into it. But if you look at the cells, you're going to get mostly these foam cells. This issue can get complicated if they are infected. And in those, you may develop a little bit of a squamous metaplasia. But having that stringy mucin and only these cells which look like histiocytic type cells, then you can be assured, combined with radiology. Remember, you're not working in a solo practice. I'm sure some of you are. But if you have a radiology available, ask the question, could this be a ranula when you're not seeing those 3 cell types? The other thing is chronic cell adenitis, which can have a squamous metaplasia and foam cells because of the macrophages and mucinous metaplasias of the ducts. And that can be, and I'm telling you, even on histology, I made that mistake once, where a chronic cell adenitis case, I said, I'm suspicious from mucoepidermoid carcinoma, and the surgeon went in, and it came out, and it was a chronic cell adenitis. So this is actually one of the common pitfalls you're going to see in this. But notice the amount of lymphocytes. That doesn't help, because mucoepidermoid carcinoma can also have lymphocytes in it. And here again, and this is actually one of my things, never ever do a mucicarmin stain. Just throw it on a case when you have lymphocytes and these cells, because sometimes the mucinous metaplasia cells will pick up that mucicarmin. So you have to be really morphologically clear that what you're dealing with before throwing any stains on it. This case was called mucoepidermoid carcinoma, and it came out and was nothing but chronic cell adenitis, where the ducts had squamous metaplasia and all these lymphocytes in the background. So this is actually one of the major pitfalls for diagnosing these tumors. Now, when you think of lymphocytes and a parotid FNA, there's again another differential, and that goes from the intraparotid lymph nodes to even lymphoma. The most common tumor in the salivary gland that you're going to see lymphocytes is Wharton tumor. Very common tumor in smokers, bilateral, but it also can be unilateral. When I was a resident, I was told you're not going to see Wharton tumor more commonly in the women, but now I see so many of these because they have oncocytes. And if the patient is being screened and they are going under PET scan, this tumor is going to light up on PET scan. So they have to biopsy it to make sure this is not a metastatic process. So what you see in this tumor is on search back, these tumors can be solid and can have cystic appearance, lymphocytes, and then oncocytes thrown into papillary folds. They can have cystic spaces with the debris in them, which can mimic mucin, or this can be very grungy debris, which can mimic necrosis. If you look at the epithelium, this is a bilayered epithelium, which really follows the rule. It doesn't not nuclear overlapping and crowding. What I want to point out is some of these oncocytic cells can be elongated and can mimic columnar cells. They can also have focal mucin in them. Whenever I see this on searchback, I always do a mammal too, because I want to make sure that I'm not missing an oncocytic mucoep. So there are oncocytes and lymphocytes. The close association of lymphocytes in the background, plus those papillary grouping with the lymphocytes almost looking at the core, is completely correlates what you see on histology on these tumors. And this is a cell block from this tumor, and you can see how you can imagine this being that papillary group. Again, this bilayering of the oncocytes, plus the crushed lymphocytes in the core of these papillae. When you don't see lymphocytes, when you see just oncocytes, this still can be a solid Wharton, or it can also be an oncocytoma, versus other tumors which have oncocytes in them. So this can be an oncocytoma, or the other tumor which has this oncocytic type, very clear cells, but it has that grouping that it follows the acinar arrangement that you see in parotid. And this is actually an acinic cell carcinoma. And it has the zymogen granules and typical morphology that you see on histology. It is a malignant tumor, but it's a very low-risk malignancy. It's very common in parotid, more common in women, and it can have different subtypes. And that's what I think makes this diagnosis very difficult. But now these tumors have a specific translocation, which is NR4A3, and there's an antibody available, which is called NOR1. And if you have a cell block, you can always do that in cases which are difficult. Most of the time, these tumors are circumscribed with a little bit of infiltration. They can be very solid growth pattern, and then those beautiful granules in them, or they can have papillary grouping or hobnail pattern, which is very important. And that's why they can mimic. They can also have a very secretory or glandular pattern. That's why they can be mistaken for secretory carcinoma, or secretory carcinoma being mistaken for acinar cell carcinoma. They can be pinky tumors with a very solid growth, but on radiology, they have a very minor infiltration. So sometimes even on radiology, they can be mistaken for a benign process. This is a tumor of acinic cell carcinoma, which is showing this, again, that monotonous cell population. They can have this very papillary arrangement, and you can see these beautiful vessels coursing through them. On Pap stain slides or on pen prep, you may just see this mass of tumors. But what I want to point out is this very important finding that you will see this beautiful sharp cytoplasmic borders and this really kind of fried egg appearance, sunny side up egg appearance. So you can see how this round nuclei with lacking nuclear pleomorphism. But some of these tumors can also be high-grade tumors. The biggest mimic is normal salivary gland. But if we look closely, these are grape-like clusters. They are not these nondescript clusters as you're seeing in carcinoma. Plus, the important finding is these ducts. So you have acini and you have ducts. So that is the normal salivary gland and not acinic cell carcinoma, because there can be cellosis, enlargement of the salivary gland, and if you put a needle in it, it may look like it. And also depending upon how hard of a smearing you are. So this is the differential of tumors which have granular cytoplasm or clear cytoplasm or then have lymphocytes. And you can see it goes from Wharton, includes even acinic cell carcinomas and some of the myoepithelial tumors. This is another tumor, which is clear cytoplasm. But what I want to point out is beautiful vacuolation that you're seeing. So it has that secretory look. The nuclei are pleomorphic. So this is actually a secretory carcinoma. And to make that diagnosis, you have to do immunostains on the cell block or do FISH for ETV6. And you can see how closely it mimics acinic cell carcinoma in the middle and oncocytoma on the opposite side. You can see, but when we look at the nuclei are very pleomorphic. So this is an oncocytic or secretory tumor with a very pleomorphic nuclei. This is a FISH. I have a FISH, and we also have NGS at Penn, but I always, when I have limited material on a cell block, I always do FISH, which I can actually even do on air-dried smears. And this tumor had that specific translocation to really make the diagnosis. So these are high-grade tumors with equal gender distribution. They are common and parotid. They have the specific translocation. They can have these different patterns, but this is the immuno pattern, which is typical to like the breast cancer pattern, which is S100, GATA3, and they're also positive for GCDFP, but they are negative for P63 or squamous markers. This is the pattern of these tumors. They can have papillary grouping, like the very secretory vacuoles and the mucin, and you can see this really bubbly cytoplasm, which actually shows up those gorgeous vacuoles on cytology. They can also be papillary and can mimic other tumors with papillary growth pattern, as I showed you in acinic cell carcinoma. They can be cystic, so you can get a lot of mucin in the background and can mimic mucoepidermoid carcinomas. But that secretory vacuoles in the cytoplasm of the cell, not mucocytes or those glandular cells that you see in mucoepidermoid carcinoma, can lead you to think of this tumor in the differential. There are special stains and immunostains that you can do. My thing is that when you are doing immunostains, you have to do immunostains that are validated for cytology specimen, because the way we fix cytology specimens is very different the way we fix histology specimens. So list is a very limited list here. It keeps on expanding every single day. And I'm getting to the age where I don't even remember some of these. So I have to, my fellow or my junior faculty kind of have to remind me, oh, there's one this stain. So, I mean, I think you have to do specific immunostains. Morphology matters. So you have to have that morphology in mind. So then you can select stains. I think the most important thing is to look at the morphology. If it's not very pleomorphic, then you really are not dealing with those high-grade tumors. And then do stains to make sure what kind of cell differentiating it is. But there is, again, a lot of overlap between these tumors. If you can do molecular profiling or if you can do limited FISH studies, you can at least diagnose some of these common malignant tumors. If you do not have those things available, my thing will be that if it does not meet the classic morphology, giving a differential, it's okay. It doesn't make you a bad pathologist, but it tells you that you are a good, thoughtful person who's thinking of the patient and not just wants to just make a diagnosis, and that can have disastrous effects. So this list is, again, very, very expensive. And it's becoming bigger and bigger by the minute, but some of them I do use. I don't use all of them. So my summary is that before we go to the slide, clinical history and radiologic features, if are available, are very important. Look at the architecture and look at the cellular elements. So it's like a flow chart that has to run in your mind. Then the differential diagnosis and what is the grouping. That grouping of the cells is very important as long as you are gentle in preparing those specimens. If you're really smearing them out, then you're not going to get to that good architecture, because what we are dealing with is very few number of cells. So this is my bucket list. It's available online and the articles, but I keep on expanding it. And I really divide them in these kind of food groups, 3 big food groups, which is very important, and they all have their own differential. And if you're using the Milan system, which I want you to use if you can in your institution, as long as your clinicians are aware that's what you're using, I think this is a spectrum of diagnoses. Some diagnoses you can really make, benign versus malignant. And then this is the middle group, which is the indeterminate group. But whatever we do is how this patient is going to be managed. So the second edition is out, and it has hit. It's going to hit the bookstands very soon. It is also available online. So I think it's kind of neck to neck with the thyroid Bethesda system. So this is actually my last slide. So thank you so much for giving me this time. But I don't know whether we have time, because I know you guys have to go to lunch also. So. You can always send me by emails or post in the chat if that is available to you, or I can even answer questions. It's up to you. So I'm going to leave it to the moderators to decide that for me.
Okay.
Thank you.
Thank you, Dr.